And for this case, it's a type A dissection that we have recently performed. So briefly looking at the CT axial cut, it's a type A dissection, no orphismal perfusion in this case, and the sizing is really following the rules previously mentioned by Professor Cito, with the just below the brachiocephalic artery, the true lumen size from wall to wall, and also down at the bifurcation of the pulmonary trunk, which is most of the time at the bifurcation of the carina as well. And that measure, in this case, 3.4 at the proximal and 2.95 at the distal. And in this case, we chose 40-40 without too much oversizing, as previously talked about. So this is the post AMDS stenting image, where you can see a very well, I would like to show the proximal. There is no dane, the true lumen opened up well. From some of our follow-up cases, we see further better remodeling in the 3 and 6 months post-op imaging. So a few things to look at the post-imaging, because not only the pre-imaging you need to think about, you also need to look at the post-imaging. The true lumen opening, visceral perfusion, any dane, and also look at the superiority branches for arch stenting. So for sizing of that, it's more complex. There are a lot of things to think about. There are controversies. First of all, the length of the FET. It concerns the length of coverage, risk of spinal cord injury. Whether we do so in the same session or two-stage extension TIVA needs to be considered. Site of distal anastomosis, and therefore that would choose the FET design and the availability of the stent graft at your unit. And look at the left subclavian artery as well, because that affects the anastomotic strategies and subsequent follow-up plans. And that then, with the left subclavian artery position and also the pathologies, we then choose for the distal landing zone. And at that point, we would choose for the size and think about the risk of endoleak and distal sign when we are doing that sizing decision. Of course, when we are looking at the CT, we also look at in acute dissection, whether there's an inward perfusion, sign of rupture, shaky aorta, or aortitis changes. So this all has been in our mind when we are looking at the CTs as such. So there are a lot more to consider, but largely the use of multiplanar reconstruction is important, and the aneurysmal side can be deceiving at the axial cut, where the aneurysm is actually longitudinal rather than a horizontal aneurysm. So the use of orthogonal view for assessment of the aneurysm is quite useful. So these are the steps I'm thinking to put down as of how to do the sizing. We would need to have a center line. EndoSize would do so with the AI, but in other programs you can do so with your own manually. And you can change the axis with the MPR, and that can expose the axial and the coronal cut to expose the arch when you can see in the CT. That we can design on the distal anastomotic side, plan for 120, 130 or 180 line of distal ceiling, and we readjust the sagittal view and coronal view to get back to the axial cut of the 90 degree, and then we measure the size from the axial cut. The sizing routine, a unit acute dissection, true size. From Professor Song, they would proceed for a down size of 10%. Chronic dissection is the longest diameter of the true lumen plus the shortest diameter, and we take an average across the two with a 10 to 15% of both size. Aneurysmal cases, we go for true size with about 15% oversize. We do not usually measure the size of the superiority branches, but we would pay attention to any anomaly in terms of the arch, for example, in bovine arch cases. So some example snapshots of the previous sizing. chronic type B dissection with narrow true lumen, history of human pericardium, adhesion previously, narrow true lumen. Therefore, we decide for a guide wire deployment. So the center line has been plotted with the Osiris in this example here, 130 millimeters zone 3. We go for the true lumen. You can see that's a very, very small true lumen, but the average size is 20 millimeter, and we went for the smallest size available, 24 standing graft. Looking at the various superiority branches, the 3D reconstruction can also allow us to have a preoperative mindset in terms of the location of the various branches. Femoral artery, for the guide wire deployment, we will need to look at which sites go into the true lumen easiest. And therefore we look into the true and false lumen distribution for a complex dissection, chronic dissection cases like this. And arch aneurysm case, again, the various axial orthogonal view to go for the size. And this is a postoperative CT snapshot where the stent is quite well placed. So all of this, with team efforts, Professor Wong and Tapua for the guidance upon surgical, preoperative, and perioperative assessment and care for this thing. I'd like to show you one